Right, so today's webinar is looking at good old plantar fasciitis. Now, I know this is one of the first and sort of core conditions that we tend to learn about when we're at university or when we're training, but I think it's a good one to have a refresh on from time to time, especially as there's new research coming out all the time for various conditions. So I've made a list there of today's can't even speak properly this morning. Let me have a mouthful of water. Excuse me. Right, so these are today's objectives, and these are some of the topics which we're going to look through. So first and foremost, the one that I've put on the list there, and one that I think is important, is anatomy. And I think knowing your anatomy well is crucial to making a diagnosis for all conditions really, but sometimes it's easy to be not quite as diligent as you should be with it, and I'm just as guilty as everyone else for that sometimes. I think also it's too easy, because plantar fasciitis is so common, just to assume when a patient comes in with heel pain that that's what it is, whereas in actual fact, there are times when it could be something else. And then I'm going to talk about the pathology, aetiology, diagnosis, a bit about differential diagnosis, risk factors, treatment. So all the usual stuff really, but obviously I've backed it all up with research. So firstly, I think it's fair to say that plantar fasciitis is probably the most common cause of heel pain that we're likely to see in our clinics. And I'm not sure who's listening today. Normally we've got mostly podiatrists, a few orthotists, physios. I think we have the odd surgeon from time to time. But I think you'll all agree it's quite a common condition. In actual fact, good evidence for the actual causes, specific causes for plantar fasciitis, is fairly poor. But generally, weight gain or occupation-related activity, anatomical variations, poor biomechanics, overexertion, the wrong footwear, all of these things are generally considered to be contributing factors. Now, plantar fasciitis, and there's plenty of papers for this, regard it as a self-limiting condition, but as I'm sure most of you know, it can take months or even years to resolve sometimes, and that can present challenges, well, for clinicians and the patients. Now, a paper by Crawford here said that 10% of the population will suffer from heel pain at some point in their lives. Now, I think this paper was written in America, so that they're mainly talking about Americans. I have heard in the UK that it's been quoted as high as 1 in 4, but I couldn't actually find a reference for that, so that is a little bit of hearsay. But either way, it is quite common. Now, the actual purpose of the plantar fascia is to provide support for the and to act as a shock absorber. And I'm going to come on to that in a lot more detail a little bit later on. So this is a nice simple sketch here of basic anatomy. I haven't got a pointer on here that I can show you, but you can see from the notes on there. And the origin of the plantar fascia is the medial calcaneal tubercle, and its insertion runs along the bottom of the foot into the proximal phalanges, into all 5 digits there. And as you can see from this image, it is a stabilizer for the medial longitudinal arch as well. Now I've gone into a little bit more gory detail here. So it's a sheet of fibrous ligament-like tissue, and it acts as a potential energy store, which then releases energy on propulsion. So the plantar fascia, which is sort of the whitey bit you can see running down the middle there, it's a thickened fibrous sheet of connective tissue that originates, like I said before, in the medial tubercle at the bottom of the calcaneus, and then fans out, which you can just about see there, stretching into all the met joints to form the medial longitudinal arch. Now you can see from this picture that it's not just the only structure in here. And I'm not going to spend the next 20 minutes or so going through every single layer and pinpointing the anatomy, but it is worth knowing, and you'll see that later when we come on to talking about the differential diagnosis. So boring as anatomy can be, having a bit of a refresh through your old anatomy book sometimes is a worthwhile use of your CPD time. So this slide is really pathophysiology in a nutshell. So essentially, when we take a step or walk, the heel makes contact with the ground on the lateral border, and then just after this contact, the tibia turns inwards, the foot pronates, and then this stretches the plantar fascia, and the arch will start to flatten. So the purpose of this is to allow the foot to accommodate for changes in walking surface, and it's effectively a mobile adapter. Now, in some people, the repetitive movement of walking or running does cause little micro tears in the plantar fascia. So this typically happens in the origin of the plantar fascia at the medial tuberosity of the calcaneus. And some studies, or one study in particular we'll talk about later, has looked at biopsy specimens of affected tissue of patients that have had plantar fasciitis, and they've concluded that while there are degenerative changes to the fascia, they don't always necessarily come with inflammation. Now, I will give you the reference for that a little bit later, and we will talk more about it, but it's not always an inflammatory condition. Now, I wasn't just going to leave it there with your pathophysiology in a nutshell, because I think it's really important to understand how all this works in order to treat it effectively. So it's all too easy for me to write a big long list of orthotic adaptations and ways to treat plantar fasciitis. But I think depending on what's going on here and what's going on with your particular patient will depend on what treatment you'll choose to prescribe. So there are, for those of you that look at the research, there's various well-known tried and tested orthotic adaptations for plantar fasciitis, like your medial heel pose and your plantar fascial grooves. But I don't believe that the same thing necessarily works for everyone, and you'll get much better results if you take the time to identify exactly what's happening in your individual patient. So let's have a little look at the mechanics, or dare I call it the physics. Now this slide, and I'm quoting Dannenberg here, and all the references are at the back. It is worth looking at some of his papers if you are interested in this. Just one little tip though, bear with all the fancy language, because it does use some fancy terms in there. But if you bear with it, it does all make a lot of sense. So it pretty much all centres around the function of the first MPJ, and he says that the good function of this joint is essential for the foot's natural functioning gait. So basically, if you have range of motion or sagittal insufficiency, then the whole foot doesn't quite function as it should, and this then affects what he calls auto-supportive mechanisms. So these three mechanisms are, and I've listed them, the windless, close packing of the calcaneal cuboid, and the locked wedge effect. So let's have a little bit deeper look at that windless mechanism. This is quite a nice picture really, because it shows what's going on in engineering terms too. So if you imagine the first MPJ is a bit like a pulley system, with the hallux being the lever and the plantar fascia being a piece of cord, you'll see that as you dorsiflex the hallux, it pulls on the plantar fascia, which then draws the heel and the first MPJ closer together. The arch then has nowhere to go, so essentially it raises upwards. So it's a bit like a winch mechanism really. As you dorsiflex the hallux here, it pulls on the plantar aponeurosis, makes it tight and raises the arch. But it's not really a new concept. So a chap called Hicks came up with this idea about 60 odd years ago, but it's been adapted and developed by various researchers since then. My only comment here would be, and this was actually written on the previous slide, and I'll quote, the mechanisms don't really rely on muscular activation, they're strictly just mechanical actions facilitated by healthy biomechanics. So this is all well and good, but as we know from the anatomy slide, there's a lot more to the foot than just bones and the plantar fascia, but it is a good starting point. Anyway, on to the next bit. The close packing of the calcaneal cuboid joint. Crikey, try saying that after a glass of wine. Not that I've had a glass of wine, but anyway. And the locked wedge effect. So basically, once the windless mechanism is kicked in, the heel is gradually unloaded and it raises from the ground, and then the body weight is then compressed right through the midfoot, which is what your close packing of the that joint that I don't want to mention again is. This puts a compressive force through the midfoot, which stabilizes it, and then what it basically does is it makes it strong enough to take our whole body weight when we're walking or running. So it makes perfect mechanical sense. But if all of these things don't quite come together as they should do, because maybe the hallux hasn't dorsiflexed enough or as much as it should do, then the mid-tarsal joint can collapse as the heel just comes off the ground. You might see that in clinic. It might present as late mid-stance, excessive pronation. You may also see an abductory or an adductory twist or a delayed heel off in one foot or the other. And then if you look, sometimes you see more flexion at the knee and the hip. All of these things can cause symptoms, not just plantar fasciitis, although plantar fasciitis is obviously a common one. And when it is plantar fasciitis, it's really effectively because the plantar fascia is being overstretched repetitively. So I suppose it's a bit like having a car where the tracking's gone wrong. Eventually, the wear and tear exceeds itself. Oh, there we go. I've forgotten I put that on there. So there's your ground reaction force coming up and your body weight coming down, and that's what causes the compressive force. Now on to something a little bit more thought-provoking now, and I've put on there ISIS or OSIS, that is the question. Now I'm not starting a debate here about a conflict in the Middle East. So, in medical terms, or if you look in your medical dictionary, anything which has an ISIS on the end of the condition means that there's an inflammation. And anything that has osis on the end sort of means that it's a condition or a process. There are other meanings with osis on the end, like diseased or abnormal, and you see this with like the word proposis, and sometimes it can mean an increase or a formation, like leukocytosis. But anyway, because we call it plantar fasciitis, we would assume that the pain is caused by an inflammation of the plantar fascia. Well, this isn't necessarily the case. In a paper there written in 2003, which I've quoted, they suggest that some presentations of plantar fascia manifest non-inflammatory degenerative processes, and so it should be termed plantar fasciosis. So basically, while sometimes there's an inflammation, this isn't always the case with every patient, and yet we still call it a plantar fasciitis with the itis on the end. I guess this could explain in some patients why ice and anti-inflammatories are effective on some patients and not on others, but I've really sort of put this in there as food for thought. I'm not suggesting we change the name of it. It's just really to highlight that there isn't always an inflammatory response. So if you've got a patient icing away and nothing's happening or resolving it, that could well be why. So let's have a little look at what causes this condition. So according to Riddle, in 85% of cases, we're not sure what causes it, but we can make certain assumptions. So in athletes, or particularly in athletic patients, plantar fasciitis appears to be associated with things like training errors or a sudden increase in activity. So maybe someone who's decided that they're going to run a marathon. Overuse is another one. Somebody that's maybe decided to start running or doing an activity on hard surfaces. So this might be someone that's taken up road running. And then there's good old inadequate footwear, so basically not having the right tools for the job. So all of these things are listed here. All of them can cause microtrauma to the plantar fascia, which effectively exceeds the body's ability to recover. So your body's not recovering enough at the rate that you're getting the microtrauma to that structure. And then the elderly. In elderly, poor intrinsic muscle strength or just poor shock attenuation can also be a predisposing factor. A lot of elderly patients as well tend to have pes planus, and the other thing is as well, their body's healing capacity just simply isn't what it used to be. So some of those sort of patients tend to be prone to getting plantar fasciitis as well. So there's plenty of risk factors for plantar fasciitis and plenty of studies to back them up. So again, I'm going to quote the same study by Riddle. They suggest that individuals with a body mass index of 30 or more are at a far more increased risk of getting plantar fasciitis compared with those who have a body mass index of 25 or less. They also found a correlation or they found that the risk of plantar fasciitis increases as the ankle joint dorsiflexion decreases. So patients with 10 degrees or less, they've put in their paper, had far more chance of getting plantar fasciitis. They also found that the less dorsiflexion they had, the more likely they were to get the condition. So if it was sort of less than 5 degrees, they were far more likely than if it was between 5 and 10 degrees. Now, the only thing I'd say about this paper is that they measured their patients using a goniometer while passively dorsiflexing the ankle. Now, that does come with its own issues regarding repeatability, but at the end of the day, they did find a strong correlation with it. Lots of papers, I've listed them there, suggest that individuals with pes planus or excessive pronation are at a greater risk of plantar fasciitis, just basically because of that pulling and stretching on the plantar fascia. A paper by Cornwall suggests that also patients with pes cavus are prone to plantar fasciitis because they're unable to effectively dissipate tensile forces during weight-bearing activities. So basically, they've got a more rigid foot that's just not taking up the shock absorption. Other anatomical risks which have been suggested in the research include limb length discrepancy, excessive lateral tibial torsion, excessive femoral anteversion, and then also people with occupations requiring prolonged weight-bearing activity have been considered at risk. And that's basically because of the repetitive tensile sort of loads placed on the plantar fascia. You tend to find as well if they work, like factory workers that are working on hard floors, policemen, firemen, those sort of professions, you tend to see it a lot of as well, just because they're standing for long periods and they're just basically walking on concrete and there's no shock attenuation. Now here's one for you. How many patients get it stuck in their heads that it's the spur that's digging in and that's what's causing the problem because that's what they've been told, or they've been told they've got a heel spur by their or for whatever reason they've been x-rayed. Heel spurs have been commonly implicated as a risk factor for plantar fasciitis, and according to one paper, half of patients diagnosed with plantar fasciitis have heel spurs, but it's not clear from that research how much influence the heel spur actually has on the condition. But then there's another study there that showed only 5.2% of patients with heel spurs are actually symptomatic. And basically that means that lots of us are walking around with heel spurs without even knowing it. So it is pretty much just an anatomical variance. Now it's not always that easy to explain this to your patient. I remember ages ago one lady who was just absolutely convinced that the spur was digging in and that was causing the pain and that surgery was the only option, and it just didn't matter how much I explained it. Yeah, she wasn't having any of it. So sometimes x-rays can cause more problems, I think, than they cure. Another risk factor, and this is worth bearing in mind if you work with the at-risk foot, and that's diabetes. So it's not just sporting fanatics who go to see specialist biomechanics practitioners. Plantar fasciitis crops up in diabetic clinics too. So often patients with diabetes that get this condition, it may be because they've got peripheral motor neuropathy, which then leads to muscle atrophy. They may often have changes in the anatomical structure of their feet, so they might have claw toes or high arches or prominent net heads. And then as well, you've also got alterations in gait. So as I say, that's another group of people that this tends to be quite prevalent in. So signs and symptoms, what does our typical patient present with? The classic presentation of plantar fasciitis is pain on the sole of the foot at the back of the heel, usually sort of quite a sharp pain on weight bearing. So usually a patient will say that the pain is worse with taking the first few steps in the morning or after they've been sitting or resting for a while. In some cases the pain can be so bad that, I don't know, maybe a patient is limping to keep the heel off the ground. But they'll normally say that the pain will start to improve with gradual activity, but then can become worse with prolonged weight-bearing activity. So while patients may not know exactly what's brought their symptoms on, and they may say, oh, it just came on, randomly, it can usually be correlated to an increase in the amount or the intensity of a certain activity. So whether they've started a new job or a new exercise, or they've changed something within their lifestyle, or even new shoes. The other one on there is being overweight. This is also a very common symptom. So the diagnosis of the condition is made on the basis of a good and thorough history and physical examination, and I can't sort of undervalue this really. So pain first thing in the morning is typical of plantar fasciitis, and it does tend to distinguish it from other causes of heel pain. It's usually unilateral, but in probably about 30% of cases, I think it is, patients will come in with a bilateral presentation, but normally they haven't started bilaterally together at the same time. Normally it's one heel and then the other one will come sort of weeks or months later. So your physical examination should include palpating the anterior medial aspect of the calcaneus for any signs of pain. And then pain may also be exacerbated by passive dorsiflexion of the hallux, or having the patient stand up on their tiptoes. And what this does is it actively stretches the plantar fascia so that it pulls on that insertion point. So if it reproduces the pain, you can pretty much guess that it's the plantar fascia causing the problem. Now, we talked earlier about tight Achilles. Almost 80% of patients have a tightness here. And then finally on your diagnosis, I've put a little note on there about MRIs and X-rays. I don't know many people that send them off straight away for these, but really the reason for this would be to rule out other causes of plantar fasciitis if you think something else is going on. Now, the signs and symptoms I've just talked about are fairly well known, but there are sometimes red flags that your patient is not necessarily presenting with plantar fasciitis, and knowing some of these will help you identify maybe other causes. Now, the ones I've listed there are pain on immediate weight bearing which worsens. So we know with plantar fasciitis they might get pain on immediate weight bearing, but it shouldn't get worse straight away. Bowed tibia, headaches, deep bone pain, burning, sort of nervy type pain, diffuse nerve pain, paresthesia or numbness, nocturnal pain, pain with resisted motions, swelling and redness, and adolescent boys. Now, obviously, some of these may be more serious than others, and worst case scenario, you might be looking at something like a bone tumour, but these are really rare. I know a colleague that picked one up years ago in the NHS, but I've never seen anything like that. So, but just because they're not rare, well, just because they're not common, rather, doesn't mean that, you know, that people don't pick them up. And I think often GPs, anything to do with the feet that doesn't seem that important, they'll refer to you straight away. But so you could be one of the first people to pick up a more serious condition, and that is based on your knowledge of doing your diagnosis properly. So this is really where your anatomy and your red flag knowledge comes in. Because common as it is, heel pain isn't always plantar fasciitis. And I think with any differential diagnosis, so not necessarily for plantar fasciitis, but I think the best way of doing it is to work through the layers of whatever you're looking at to see what's there. So maybe start with the top, so look at what's going on with the skin, soft tissue, muscles, nerves, and then working your way down to bone. Now, I've listed a few suggestions here, but their history will also give you some clues as to what's happening. So perhaps if you've got a patient that's come in and they're describing a sudden acute knife-like pain, this could be something like a plantar fascial rupture. Or if they've had a history of an acute impact injury, perhaps they've got a bruised heel or fractured calcaneus. Swelling and redness to the back of the heel could be a bursitis. And if you've got pain with resisted motion, you might be looking at something like a tendinopathy. So your flexor hallucis is in this area as well. So if you're doing persisted motion, you could identify this rather than the plantar fascia. Nervy ones sort of tend to present with a completely different description of pain anyway. Usually patients describe that quite well. Tarsal tunnel syndrome is likely to present with a diffuse nerve-like pain over the plantar surface of the foot. What else have we got on there? A trapped post-tib nerve. And they're likely to have nerve pain just on the medial heel because that's where it innervates. And if it's the abductor digiti quinti nerve, it's likely the patient will feel a burning pain sort of over the whole heel area. Pain that worsens with prolonged weight bearing could suggest a stress fracture. And if you're dealing with adolescent boys, don't forget Sever's disease because that is common in that age group. Things like bowed tibias, kyphosis, headaches, deep bone pain, or nocturnal pain could all be signs of something a bit more serious, bone tumours or Paget's disease. And if in doubt, then I would refer these on for further investigation right away. So on to treatment. Most of these I think we're fairly well familiar with. There is always an argument that plantar fasciitis is self-limiting, and I've certainly heard GPs say that, so therefore there's no need to do anything, just go off and it'll resolve. But it can take months or years, and lots of patients just don't want to wait that long, or they can't wait that long. So the list of stuff I put on there, we've got orthoses, stretching exercises, cold bottle rolling, so your ice bottle that you keep in the freezer, or your Coke can that you roll over the bottom of the foot. Cross-frictional massage, so getting in there with a thumb, either they can do it or a partner can do it, or someone else, to go across the structure of the plantar fascia to work that and loosen it up. That can work very well. Lifestyle changes, so things like losing weight, physiotherapy, cortisone injections, and then last but not least, surgery, although that's not always, generally not indicated or not necessary. Now, when I wrote this presentation, I did find a few papers which gave a small consideration towards nutrition, although I haven't mentioned it on there because I couldn't find the research really to back it up. I guess really with this one, it's looking at a more sort of holistic, bigger picture, if you like, because it's looking really at just general good nutrition and the effect that has on tissue repair. So that might be something that's worth considering if you've got elderly or maybe ill patients that have got plantar fasciitis and you think they're probably not getting the nutrition that they need for the healing process. But as I say, that might be, if you've got a nutritionist or a dietitian that you work with, that might be something you want to refer to them. So icing and anti-inflammatories that I've listed on there work for some patients and not others. And we talked about this earlier with the ISIS or the OSIS debate. So it just might just be down to the fact that it's not inflammatory in that patient. Lifestyle changes and losing weight are always good suggestions if required, but the problem is you're largely reliant on the patient there to make that change, and if they're very overweight, that's not the easiest thing to do. If you do have access to a physio, then I would certainly use them. I always think you get better results and compliance if you take that multidisciplinary approach. And as I said, if all else fails, there is surgery, but I think that is extreme, and I don't know of many patients that just haven't got better to the extent they've ended up being referring on for surgery. So, as I say, not very common. Now, there's lots of papers out there, and I'm sure everybody probably knows of one or other of them. Lots of papers that support the use of functional orthoses for the treatment of plantar fasciitis. And if I went through all of them, that would make a presentation on its own, especially if I pulled them all apart. So some look at different types of orthoses or different corrections or different materials, or whether they're prefab or custom made. But many of them use different outcome measures, and that does make it difficult when you're comparing studies. And I think it's always important, if you find a paper that says orthoses don't work, then I would look very carefully at the methodology, because well, I would say that I'm a podiatrist and I think they do work, but you do often, people will quote that they don't. But again, that's a whole new presentation, which I'm not going to go into now. So I've picked out a couple of papers here as examples. This study here at the top looked at 236 participants, and they concluded that prefab orthoses were superior to both custom-made and stretching alone. But that doesn't mean that the other two didn't work, because actually when you read the paper, actually the custom-made orthoses and stretching alone also showed really good results. So, and then there's a study here by Lynch. So this was a randomized control study of 103 patients, and they looked at 3 treatment categories. So one was anti-inflammatories, another was just accommodative, comfy insoles, and then the final was mechanical. And the mechanical consisted of low-dye taping for 1 month, followed by rigid custom-made orthoses for 2 months. And what they found after 3 months of treatment was that 70% of the participants in the mechanical treatment group, so they were the ones with the taping and the custom-made orthoses, rated their outcomes as excellent or fair, compared to the other 2 groups. So these are just 2 papers, but there's lots more out there if you want to look for them. Now the final paper I've added here, and this is a very recent one, only this year in fact, And while it shows that correcting the foot position helps reduce symptoms, they make the point of discussing that their outcome measures, so that, sorry, they make the point of discussing that, let me just have a mouthful of water. Yeah, so basically, while they're looking at prefab insoles and other insoles, they talk a lot about their outcome measures. What they're suggesting is that perhaps other papers are looking at traditional things like the pain or disease-specific quality of life, and what they should be looking at is detected improvements in things like weight-bearing function. So they're the questions they should be asking, not a case of just whether the pain has decreased. And I think that's really something to bear in mind when you're measuring your improvement. So rather than just having a pain scale, look at what the patient's doing beforehand and then what they can accomplish at the end of it. So weight-bearing function there. I think that's also something that's worth bearing in mind when you're looking at research. Now, stretching is an excellent tried and tested treatment, and again, there's tons of research papers out there which advocate it. But I think that's largely because tight calves are so common in patients with this condition. So, I mean, I tend to prescribe a lot of calf stretches for all sorts of conditions, and also as part of the patient getting used to their orthoses. One interesting recent paper here that I did find, this one by Piper, and again this year, they found that myofascial release to the gastroc, soleus and plantar fascia is a good and effective treatment for plantar fasciitis. So that might be something that's worth exploring, especially with someone who's got particularly tight calves. I think the current thinking with calf stretches is holding the stretch for 20 to 30 seconds, repeating it 3 times and then doing it 3 times a day. And I don't know about you, but I find the problem with this is that patients just aren't good at doing their exercises. And personally, I still find probably the best way of getting them to do this is just standing on a book or a piece of wood and then dropping their heels off while they wash up, do their hair, clean their teeth, or whatever else they do several times a day, and stand there for a couple of minutes. So despite what the research says, I think sometimes you still have to be practical with it. And you might have a great piece of research which tells you how to do this wonderful stretching exercises, but if your patient isn't going to do it, then it's not going to be a lot of good to your final outcome. Now, cortisone injections certainly have their place, and the research shows that they work compared to the placebos, but they are short-term and they do come with risks, albeit quite small ones. Now, obviously, a ruptured plantar fascia isn't a small thing, but the risk of it happening is quite small. I've referred patients for cortisone injections in the past. It's usually in those patients who have sort of become chronic and nothing else seems to be working. And I think really in my experience, if nothing else, it breaks the pain cycle just for long enough for you to get them going with some stretches or orthoses or whatever else you've prescribed. So yeah, certainly has a place. Now this slide, well, it's not evidence-based at all, I'm afraid. It's just purely based on my experiences as a clinician. And I have had a handful of patients like this over the years, both NHS and private. And they presented to clinic with heel pain, and to put it bluntly, the whole thing just hasn't made sense. So not even after a lot of reading up on differential diagnoses or referrals for further investigations. When I first started practicing, I wasn't really aware of yellow flags or anything like that. And I never really thought out of the box of, I'm a podiatrist, you have heel pain, and that was it. There are odd times, however, that I've had when a patient has had a lot of other issues going on, be it psychological or otherwise, and somehow that's manifested itself in their pain. And I remember one story which I suppose was quite funny in a way, and I will obviously not mention any names. But I had a chap come to see me with heel pain, bilateral heel pain, and the whole thing, like even the red flags, the differential diagnosis, nothing made any sense at all. And I think I tried him with some off-the-shelf orthoses, just some really mild ones, just sticking some wedging, on a freel and that kind of thing. And then I found out he'd also been seen by the NHS, and I talked about him with a colleague of mine. who worked for the NHS, and my colleague said, I'm not sure about this patient, I think you need to write your notes up properly, because I think he's the sort of guy that's probably going to sue or something. He said, so I've covered my back, I've sent him for MRIs, blood tests, the lot. So anyway, he never came back for a review and I forgot all about him. And then a year or so later, I had a lady came to see me for a follow-up, and the long and short of it was my Mr. patient had become Mrs. patient. And had absolutely no recollection of ever having heel pain, and she just bought a whole bag of shoes in. Obviously hadn't been used to wearing ladies' shoes before and wanted to discuss footwear and work shoes, and so the whole thing was a bit baffling. But certainly when he first came to see me, he was very, very adamant about this heel pain he was getting, so I never did understand what was happening there. And I have had, as I say, a handful of other sort of similar kind of cases like that over the years, so hopefully you won't. Now, you may have noticed that I've talked throughout this presentation a lot about the causes and the diagnosis of plantar fasciitis, far more than I have the treatment. And that's because while there's there is a great evidence base for treatment such as stretching and functional orthoses, I think you have got to keep it in context. So it's no good me talking for the majority of the last 45 minutes about intensive stretching and rigid functional orthoses and how great all the research is, if your patient is 80 years old with diabetes and arthritis. Essentially, I think the most important thing is not just making the right diagnosis, but also working out exactly what's likely to be causing it in your patient. And that's when it comes back, as I say, looking at your Windless Mechanism, taking a good history, and so on. And I'd say that for any condition, it's not just plantar fasciitis. Also bear in mind that there may be more than one contributing factor to their pain. So you might find in your examination that they have tight calves and flat feet. But if they've got a BMI of over 30, you're not necessarily going to have great results if weight loss isn't addressed too. Also think about outcome measures and that paper that I mentioned earlier, and patient expectations. So it may be that the pain won't resolve completely, but their ability to do things may have improved. And a typical example of this would be, say, a runner who gets symptoms of heel pain after he's run 5 miles. Now, the simple answer to this, and I have heard this said to people, is, well, only run 4 miles or don't run. But there is lots that you can do treatment-wise to get them reaching the 10-mile or even the 26-mile mark. So, on that note, happy treating. I will apologise for the state of my references. If any of my former lecturers see this, they'd probably die, because a lot of them I've cut and pasted, so I haven't fussed too much about where I've put the commas and full stops and the dates. But if you want to look at any of them, you can kind of, if you look them up on the internet, you can get the gist of which ones I'm quoting there. So, any questions? You have got a little tab on your screen which allows you to type questions in. Can you recommend any outcome measures? Gosh, I've got a whole presentation on outcome measures, which I did ages ago, and I'm just trying to recollect. I think this really depends on your type of patients. If you've got children, I think the easiest way is to have a line and have a smiley face and an unhappy face and get them to mark sort of where it is in terms of pain. And so that's really similar to just having your 0 to 10. There is evidence out there that it's not a great way of measuring outcome measures. I think it is really important to look at what they're physically doing and use that as well. But yeah, I do have a load of stuff on outcome measures, so maybe I need to do, maybe I'll blog about that next month or something. Does it only present in the plantar calc? Yes, technically it does, because that's the insertion point. But then if you're getting stretching or pulling or micro tears of the plantar fascia, sometimes you can actually get it all the way along the plantar fascia. So the most common place is to get it underneath the calcaneus, but I have quite a few patients do get it underneath the arch as well, and even extending into the met heads. Do we get to keep the lecture notes? You will get an email afterwards. I have emailed lecture notes out before, but if you go onto the LBG website and look under education, you can access this webinar again. What about ultrasound, shockwave therapy, or even non-steroidal anti-inflammatories? Anti-inflammatories, yes, I would if I thought it was inflammatory, but if it's not inflammatory, then it's probably not going to help much, so I would probably try the stuff first. Ultrasound and shockwave therapy, I didn't list them on there, but I probably should have done. I guess probably I would lump that more under physio and leave them to do that. But yeah, there are papers out there and there is evidence to support the use of ultrasound and shockwave therapy, so that might be an option too. Which biodevice is best for treating this? I'm glad you're asking about biodevices. It depends entirely on your patient. So if you've got an elderly patient that hasn't got much range of motion, you'd want a softer device. If you've got someone who perhaps pronates very heavily in their runner, you'd want something a little bit harder or a bit denser. So the answer to that is you could use any of them. It really depends on the patient. Do you have a recommended taping technique? Yes, I do. I'm not massively keen on taping just because patients have to redo it unless you get them in every couple of days or so, and they tend to get in a right old tizwas with it and get themselves tied up and a bit mummified. There's quite a good taping book, which I can see on my bookshelf, but I can't reach it, called Taping Techniques. And that doesn't just look at the foot, it looks at the whole body, but that's got several, if you look for it on Amazon, that's got several suggestions in there for taping the plantar fascia. When I have used it, and you do need the right patient with this because they do have to be compliant, when I have used it, it has worked well, because what you're effectively doing is holding the foot so it takes the strain off the plantar fascia, and if you do it properly, it does work instantly. Is K-tape helpful? K-tape stretches, doesn't it? I think. Can you comment on the new research on heavy load strength training? I probably want to look at that and read it again before I commented on that. I think, again, I have seen some of that, and I think that works well with your athletes and your very active patients. I think what you've got to think about is the sort of patients you're seeing from day to day, and if you're just seeing sports people, then yeah, that might be something that's worth doing or working with your physio to do. People that stand all day, depending on what their footwear's like, I'd probably go for the full length one. I'd say possibly put a medial paste on there, but again, you couldn't say without seeing the patient. If they're standing all day, they're working in something like a factory in a hard floor, then you'd want the medium density, probably full length, which is giving you a little bit of shock attenuation. You'd also want them looking at their footwear as well. Do you ever use heel raises to reduce the loading on the plantar fascia? Yes, I have done, and I've also used it with Achilles tendonitis. The thing to remember here is it's only a very temporary, immediate relief. Don't want to get the patients used to it. So if it's really, really chronic, and they're the sort of patients that come in limping, then you could do that because it instantly takes the strain off, but then you immediately need to get them doing stretching exercises so they can completely get rid of that heel raise. You certainly wouldn't want it long term. Can you think of any rationale for wearing minimal running shoes to help plantar fasciitis? Again, I've got to say this depends entirely on the patient. I think certainly Simon Bartold that does some stuff with LBG will comment and go into a big debate about this. I'm not a fan of minimal running shoes, only because I think it's a bit of a fad, and I've had lots of people quote to me that, oh, they're the next best thing, this is what you should be doing, this is the natural way of walking, and so on and so forth. Well, that's great if you're running on mud, forest floors and sand, but we're not. Having said that, my husband walks around barefoot and runs barefoot and has never had any problems, and he boasts that he has perfect feet, and maybe he has. But I've also seen a lot of patients that have been taken in with this minimal running concept, and they've had no problems before, and then they've come to see me with plantar fasciitis, and I'm actually seeing someone like that at the moment and trying to get him to understand that actually it's the shoe that's probably caused the problem. Is quite difficult because you spend so much money on them, but it depends completely on your patient and what their foot function's like. What is the average recovery time for plantar fasciitis? I think it does vary greatly on the patient, but I would say they should start to see improvements within 4 to 6 weeks. I also think if you can, as I say, if you're doing stretching and maybe if you can get a physio on board as well, and then you tend to see better results quicker than if you're just doing orthoses. Has that worked? No. Let's try stretching exercises. Has that worked? No. Let's try cortisone injection. So if you can sort of lump a few things together, then you should generally start to see some improvement within 4 to 6 weeks. Have you experienced with patients who've using the Vibram individual toe? Yes, that's a patient I've seen at the moment, an American chap who's running around here trying to lose weight and invested in a pair and has now got plantar fasciitis. So I'm not a massive fan of them, to be honest. Oh, someone's put there, we use laser on low level setting, which nearly always reduces pain by 50% after 3 visits. Wow. I think I'll have to get one of them. My only thing would be, does it come back again sort of weeks or months later? But yeah, that sounds good. Might have to look into that. What footwear would you suggest for people that stand all day? A good pair of well-fitting, supportive, shock-absorbing trainers, or if they're working in sort of factory-type places where they need steel-toe capped boots. I think some places, if you go to HR with a letter, they will. Normally, these sort of places give you the cheapest boots they can if their boots are being supplied for work. But I certainly know when I worked for the NHS, there were a lot of firms that would give better footwear. So shock absorption and foot support, really. Thank you, me too, about the Vibram trainers, good. Oh, I hate this one. How would you suggest weight loss to a patient without causing offence? I don't know, it's a tricky one. I'm quite slim, so I always find it really hard when someone comes in that's quite overweight to say, right, okay, you need to lose weight, because they immediately look at you and say, oh, it's easy for you. I don't know, I guess that comes with your bedside manner, really. I remember once I was working we worked in the NHS and we worked in cubicles, so you could hear like the person next door, and I didn't have a patient. And the guy that was working next to me, very, very clever, very knew everything, but he wasn't that great with patients. And this lady came in and she was massively overweight, and I think she had ankle pain, and he was trying to sort of go about it and tell her to lose weight, and she just wasn't getting it. And in the end he said, look, for goodness sake, it's like trying to balance an orange on a toothpick. And she got very, very upset, and he got disciplined. And so I mean, he did probably have a point, but it's not the best way of putting it to a patient. So yeah, good luck with that one. Would you put an insole in a trainer? Yes, I would. Most trainers, you can take the insole out, the existing insole or the liner of the trainer, sit with one which perhaps you've modified. Actually, I suppose with going back to the weight loss one, you can sort of tailor it around healthy eating and that sort of thing. I do think a lot of patients that are overweight know it, but some of them are in denial. Oh, that's a good point. Somebody's put there, sometimes asking an overweight patient if they think their weight may be having an effect on their pain. That's a really good idea, actually, because you're putting the ball in their court. Mind you, if they say no, I don't know what you do then. But that could be a good way of addressing the topic. So say to your patient, do you think your weight is having an effect on your pain? And then wing it. And someone's put, I think it's part of our role to help motivate towards a healthier life, and restricting refined sugar in diet works well. Yeah, I totally agree with that. And I think, again, that's looking at the bigger picture, and it's not just thinking, you know, I treat feet and you've got foot pain. You need to think, and then healthy lifestyle. And the sort of patients that get motivated with that are also more motivated to do things that will help them with their problems, like, you know, stretching exercises as well. Right, is there any way, I thought about this earlier actually, is there any way of distinguishing between a fasciitis and a fasciitis, or is it just a case of seeing their response to ice and anti-inflammatories? If there is, I'm not sure of it, I suppose, apart from the obvious things such as maybe swelling and heat that you might see with an inflammation. But I'd be inclined to think, I suppose really I wouldn't just give ice and anti-inflammatories alone without doing other stuff anyway. So it's kind of difficult to tell. And I also think if it is an ISIS or if it is an inflammatory, then you've still kind of got to do the other things as well. Because if you're only doing the ice and you're only doing the inflammation, you're not actually addressing what's causing the pulling or the aggravation in the first place. But no, I don't think there's a quick way of distinguishing that, or if there is, I don't know. Someone else has put, when using a laser for acute problems, we use FS06 socks and maybe gel heel cups and try to issue orthoses. That sounds like that works well. Right, someone's put, I recently saw a patient who had both plantar fasciitis and Achilles tendinopathy. Is this common? Yes, it is. The two things do tend to go hand in hand. And if you think about all of those, both those things kind of work in the sagittal plane. So if you think about your patient functionally and walking, if you've got a tightness in the calves, which we said earlier 80% of patients do, then your calves attach into the calc by the Achilles tendon, then it's the same, and then the plantar fascia basically inserts the other side, if you like, but put very crudely. So quite often, if the patient's gone around like that for long enough, either the Achilles pain starts first and then the plantar fasciitis comes on, or the plantar fasciitis and then the Achilles tendon. So yeah, you do tend to see that a lot, especially with patients with very tight calves that tend to be very active. Someone's just put, what laser was suggested for the pain? I have to go back now and have a look. Oh, it doesn't say. And he's left the conversation now, I'm afraid. He just said when using a laser, so I don't know, I'm afraid. I still think, and this is just my opinion with this, lasers and all these things are great if they work and help your patient, but they're not necessarily addressing the mechanics behind what caused the problem in the first place. So if, and I put this very, very simply, if they are excessively pronating and they've got tight calves and that's pulling on the plantar fascia or the insertion point, you can laser it, you can ice it, you can anti-inflammatory it, you can do all those things, but they're just treating the pain, they're not treating the cause. So that they obviously they do have their place, but I still think you have to look at the bigger picture with it. Do I use gel heel cups? Yeah, sometimes. Mainly, let's say, with the patients. I do actually a lot with young lads with Sever's disease, just because it gives it a bit of cushioning and makes it softer, although Sever's disease isn't plantar fasciitis. But those that have got very acute heel pain, gel heel pads, just really because they feel nice. Thanks very much for the webinar. Will you be doing any more soon? Yeah, I tend to do them about every 3 months or so. So as I said, they're all on the LBG website. The feedback I've had generally is better when I've talked about conditions that clinicians can take stuff away and then adapt it to practice, more than when I've just looked at loads of research papers. So the next one I'll probably do a condition again. Would you use a topical analgesic on the Achilles if it is involved? I never have done, but I suppose there's no reason why you shouldn't, but like those topical things they give you for toothache. Again, I think if something's very painful, if you can just break the pain cycle and then get them to do the treatment or the exercises you prescribed them, then if it helps, then yeah, good idea. Again, probably quite a good one with children that don't necessarily understand what you're doing. Oh, there we go. Someone's put a suggestion for the next topic, post-tib dysfunction. I did a blog about that the other day, so I might do post-tib dysfunction. Actually, I quite like that one. I like treating that one as well because it's quite an obvious thing that they come in with, and you can get some really good results with it. So thank you. I'll do that. Where is your blog? Right, if you go on the LBG website, which you should have on your email that told you about this webinar, or you will get an email after this webinar. If you go on their website, they've got a tab or a section called Education, and then in there they've got blogs, and then there's me in there, and there's a few other people as well. So, in fact, they've got loads and loads of educational stuff on there that's worth looking at. Right, I think I'll call it a day on the questions. If anybody does have any comments or questions, you can always, as I say, email in on the link you'll get with your email afterwards. As I said, you can watch this webinar again. If you want the references, then you could just pause the webinar when you watch it back on the LBG website, and then look them up if you want to. So I'm going to call it a day. Okay, thanks for listening, everyone. Take care.